I think all of you must be very pertinently aware about the fact that management of systemic lupus erythematosus is somewhat very tricky, and we don't have clear-cut guidelines and per se experience also in Indian settings to manage these patients. So management of SLE, I would be focusing predominantly on these four caveats, like lupus nephritis, neuropsychiatric lupus, cutaneous lupus, and other systemic manifestation of lupus. Why lupus nephritis? As what madam had already highlighted, that almost 50 to 60% of the patients will develop lupus nephritis in some or the other form with varying severity during the course of their life. So almost 1/3 will have lupus nephritis at the time of diagnosis, 3 to 5 over a period of say 10 years, and 1 in 5 with lupus nephritis is thought to be undiagnosed. This is what is about the natural course of disease and natural course of glomerular loss. So if we focus it over here, that the amount of glomerular loss or nephron loss with podocytopathy, which would be occurring at the age of 100 years, is almost occurring after the first attack. Okay, so this is what actually points towards the gravity of glomerular involvement or renal involvement in lupus nephritis. That even one attack, even one manifestation will give rise to almost 50% of the loss of glomeruli or nephrons. So we have to be on our toes in management of lupus nephritis. Okay. And gradual nephronal loss which would be occurring without treatment would be faster than what we can expect. Assessment of renal function will give a pointer towards the gravity of problem, the severity of renal involvement in predicting the prognosis as well as in monitoring. So urine analysis, very important one. What all things in urine analysis can anyone point? Anyone? Bolo? No, I just want to keep it much more interactive. Otherwise, the management part is somewhat not so entertaining. So, what all things in urine analysis? Anyone? Okay, protein, caste, RBCs. Anything else? Anything else? Okay, biomarkers. There are a few biomarkers which are available which can actually per se tell something that what exactly is happening at the level of kidneys in lupus nephritis as well. So the scope of biomarkers is much high and I won't be able to incorporate everything in my one presentation. So protein excretion in urine, we can do it by two tests. One is the UPCR, urine protein create ratio, and second would be 24 hours urinary protein estimation. Out of these two, 24 hours urinary protein estimation would be better, as the diurnal variation as well as positional variation and the dynamic nature of protein loss in urine is usually eliminated if we are actually taking a 24-hour sample. So what my advice for most of the residents, it would be that better to go ahead with 24 hours urinary estimation. One thing is it is cheaper as compared to UPCR, and second thing is that the dynamic nature of protein loss is usually eliminated. So much more sensitive as well. Serum creatinine, madam has also highlighted that if at all the first presentation itself, if the patient is coming to you with AKI with a serum creat of more than 1.4, definitely it has a poorer prognosis as compared to the one who is not coming with that. Renal biopsy, another important test, which is somewhat cumbersome to do in our setting, but definitely indicated if the suspicion is very high. So before going to actual management of lupus nephritis, this is what is the flow chart which I have highlighted. So the crux of the disease, this immune complex formation, deposition in the glomeruli and its uptake by the macrophages which are present in the renal parenchyma, activation of the terminal complement pathway for elimination of the antigen-antibody complexes by the macrophages, and active glomerular, actually the active ligation hona chahiye, that's somewhat spelling mistake. So active glomerular cells producing FCR ligation. So this is important step, and the management and the drugs would be actually hitting at these 2-3 things. So you need to understand that what exactly is happening at the renal level. Coming to the actual treatment. So this strategy of therapeutic goals has actually been taken from oncology. Okay, so in oncology, what all the SOPs and what all the treatment schedules which have been designed are designed accordingly that we have to make the tumor cytoablate at maximum time and in maximum space wherever it is present and maintain the phase as long as possible. Okay, Hindi mein bole to we have to hit it hard in the first step. Jitna zyada cytoablate kar sakte ho kar lo. Definitely there would be collateral damage as well. And usi stage ko aage maintain karo. So this is again a concept which we have in rheumatology, which we have borrowed from oncology. Here itself also what we do is make the immune system per se, tame the immune system so hard with immunosuppressants in the induction phase or initial phase, achieve remission and maintain that remission for the patient's whole life. This is what is our aim. Okay, so this is what is the concept which you need to understand. Diagnose it early, attain remission by hook or crook, and maintain remission. Okay? I think clear? Pakka? So with initial therapy starting and starting of initial therapy means induction regimen. Continuing with this induction regimen for at least a period of 3 months to a period of 6 months. It can be extended up to 9 months with one drug. Consider it a cyclophosphamide. Attain remission. Better way, the PR and CR, it is complete remission and partial remission. It is better to just remember these two words of complete remission and partial remission. I will explain it to in my further slides. After you achieve remission, maintain the remission. Okay? And especially even in remission, there are 3 things. That is, one is clinical remission, that clinically how much the patient is better, whether he is going near normal. Second thing is lab remission, laboratory remission. उसमें भी आता है immunological remission and renal remission. अलग-अलग पैरामीटर से इतना मत सोचो. Just remember that you have to achieve remission. Okay? Diagnosis हो गया. Lupus nephritis तुम्हारा diagnosis है. Now you have to start the treatment. Hit him hard. Hit the patient with adequate immunosuppression. Achieve remission. After the remission has achieved, maintain remission. Your remission should be maintained for such a long time that the patient should be per se disease free for his entire life till the time he is alive. Okay? So this is the concept. In class 1 lupus nephritis, as what madam had also highlighted, classification is histology based. Clear? There is no clinical classification for lupus nephritis. It's histological always. So class 1, that is minimal mesangial. There is only small minuscule of immunoglobulin deposits and inflammation, which would be actually only pertaining to the mesangial space. So not much immunosuppression is required, but these patient needs a close follow-up that anything deterioration in the renal functions or extra-renal manifestation would be requiring treatment. And usually, because no much RCTs are available as far as the class 1 lupus nephritis is concerned, because class 1 lupus nephritis is again an incidental diagnosis. It's usually not because class 1 patients will be somewhat okay, somewhat normal. Okay, so no much immunosuppression is required for class 1 lupus nephritis and is usually directed towards the extrarenal manifestations. In class 2, again, no evidence-based data is available, but all patients should be treated with RAS blockade, that is ACI inhibitors. My first choice would be ACI inhibitors and not ARBs. The second thing is that if the patient, these are the EULAR recommendations. EULAR is European League Against Rheumatism. So it is an organization of rheumatologists who actually gives directions and guidelines to the practicing rheumatologists around the world. So what they recommend that if at all the patient with lupus nephritis is having a proteinuria, this is a 24-hour protein estimation, having a proteinuria of more than 1 gram with should be supplemented with moderate dose of corticosteroids plus or minus azathioprine. So higher immunosuppression with endoxan is usually not indicated, cyclophosphamide is usually not indicated. While KDIGO, they are somewhat on a back step and they are waiting for the proteinuria to exceed 3 gram. And their first choice would be for calcineurin inhibitors as a management is minimal change disease. Okay. Class 2 and class 3 and class 4 lupus nephritis, the most dreadful one and definitely needs to be managed in appropriate way and most judicious way as well. So again, the initial therapy, as what I said, hit hard. Initial therapy hit hard. Achieve remission by hook or crook. So the first step would be achievement of remission with the help of cyclophosphamide. See, multiple induction agents are available. Cyclophosphamide, take it cyclophosphamide, take it rituximab, take it voclosporin. Even there have been reports with the use of leflunomide, azathioprine, multiple of them. Our choice would be going ahead with cyclophosphamide because cyclophosphamide in Indian setting and especially what the experience of Indian rheumatologists is that Indian lupus behaves somewhat differently than what is European lupus. Indian lupus, the incidence, though I have taken this data from EULAR, where it has been mentioned about 50 to 60%, in Indian lupus it is much higher. It is almost going beyond 70%. The severity of Indian lupus is also higher as compared to the European. European means European Caucasian population mein hone wala lupus. Definitely, okay. And in India, the support system is not good. Kitne patients ko dialysis milta hai hamare yahan pe. And the sorry state is that almost 9 patients out of the 10 would be women. That too of fertile age group. So definitely we have to be much more cautious in treatment as well. In diagnosing as well as in treatment as well. We should take one step further always. So this is a landmark paper which was actually published in Lancet, and this was the path-breaking thing which actually happened in the management of lupus. Before 1976, it was per se that whether you use pulse therapy with methylprednisolone in the treatment of lupus nephritis per se was not very well documented one. But this was one of the landmark paper which actually changed the arena of treatment around the world. Okay, so there has been definitely the beneficial effects of methylprednisolone pulse therapy in treatment. With the advent of cytotoxic drug, which was the first cytotoxic drug which you know of, general knowledge? अच्छा, cytotoxic drug का concept कैसे आया? कब आए? Cytotoxic drug आए कब? पता कैसे चला? When did the world recognize that this can also be there and this can also be a part of treatment? Who knows Siddharth Mukherjee? My Banali Bandhu should be very proud of him per se. Who is Siddharth Mukherjee? He wrote one book called as Cancer, Emperor of Maladies. So he has actually portrayed the life cycle of cancer as a person. So the concept of use of cyclophosphamide came much later, but it was an observation per se in the post-World War II. That all the soldiers who had an exposure to nitrogen mustard produced cytopenias. They had persistent cytopenias, and this was actually studied further, and the scientists were able to find out that what exactly are these nitrogen mustards all about. They were able to make alkylating agent, like cyclophosphamide is a type of alkylating agent, and the therapeutic in the management of blood cancer came first, and then it came to rheumatology and management in lupus nephritis. Okay. So something very historical and something really very sensational as well. So Cameron et al. In 1970, the World War II had ended much before that. So he have found that the patients with DPGN on oral cyclophosphamide therapy, almost 5 of the 6 patients recovered, which was further channelized by Chan et al. He also showed that most of these patients are actually able to attain remission. Then it was further channelized in the NIH protocol, that is the National Institute of Health protocol, in which it advocated for the use of IV cyclophosphamide. The starting of the story, which had been with oral, was shifted over to IV. Now we are only using IV, most of the centers, of giving monthly doses of cyclophosphamide at 0.5 to 0.575 grams per meter square. This is according to meter square. I will also highlight various trials as well as the regimen in my further slides. Azathioprine as an induction agent, reports are there, but truly speaking, the results are not that well sustainable in Indian patients. So better to use azathioprine as a maintenance agent than to use as induction agent. MMF for lupus nephritis, yes, we can use, especially in those patients who are having contraindication to the use of cyclophosphamide. MMF could be a better modality, but again the problem with MMF is that, okay, let me explain in other way. What is MMF? Mycophenolate mofetil. What is MPA? Mycophenolic acid. Okay, so MMF in the induction regimen, if we are using it as an induction drug, the dose comes out to be between 3 to 4 grams or even more. Okay, the problem with MMF is that once you initiate the therapy with MMF, these patients are having very bad GI symptoms and the patient tend to discontinue that. And I don't know why, but Indian patients, these GI side effects are much higher than what has been documented in the US as well. Okay, so again, MMF, contraindication to cyclophosphamide, it can be a drug of choice, but not very well. Okay, so we are not able to achieve that amount of concentration of drug required for initial therapy. The choice between cyclophosphamide and NMF, ancestry limited studies suggest that the black Hispanic patients, again not very much concern for us, they achieve a good response with mycophenolate mofetil, and patient's preference, it would be better because it's an oral medication, the patient need not be getting admitted and the monitoring is also somewhat easy. Class 5 lupus nephritis needs a special mention because class 5 lupus nephritis, the inflammation is not that severe. It is the membranous or the hyaline changes which are taking place at the level of glomeruli, and proteinuria in one stage would be much more alarming thing that needs to be addressed than just immunosuppression. However, there is entity called as class 5 plus class 3 or class 5 plus class 4. In that case, the treatment is again directed towards the class 3 and class 4 lupus nephritis, which I have told you. Okay, so these are the flow charts. The class 6 lupus nephritis, nothing much promising with immunosuppressive agents, as more than 90% of the glomeruli already sclerosed. So these patients would be requiring hemodialysis as well as renal replacement therapy at much more frequent intervals. So these are the regimens: NIH regimen, Eurolupus regimen, oral cyclophosphamide regimen, and the MMF. In the NIH, it was 0.5 to 1 gram meter square monthly doses for 6 months. Eurolupus, it is a 2 weekly one with 500 milligram. In oral cyclophosphamide regimen, it was 1 to 1.5 milligram per kg per day with a maximum dose of 150 milligram per day for 2 to 4 months. MMF, which I have already told you. So if you want to take a pic, you can take a pic. I will mail you my presentation after finish. The other initial regimens, should I? Achha. This is all about the regimens. Okay. These are the other initial regimens, other drugs which can be used, which include rituximab, availability is a big problem. Azathioprine, not very good as a induction agent in Indian patients. Mycophenolic acid, again the tolerability is a big issue. Cyclosporin, age group as well as the nephrotoxicity monitoring again makes it somewhat difficult to monitor a drug. Tacrolimus, Indian patients definitely not very good effects. The B cell inhibition. Friends, just concentrate upon here. This slide is very important for treatment as well as for exam point of view. Okay, so anti-CD22, the progression or the development of a B cell from a pro-B cell stage to a mature B cell and a memory B cell has been highlighted over here. So anti-CD22, it is iprotuzumab. Anti-CD20, it is rituximab, ocrelizumab, obinutuzumab and ofanitumab. So the availability is rituximab is available in India by multiple brands. Obinutuzumab is injection Gloria is getting available kuch centers pe. Ocrelizumab, ofanatuzumab is not available in India, so forget about it. The proteasome inhibition where it is indicated in which cancer treatment proteasome? Bortezomib? Multiple myeloma. So plasma cell dyscrasia. So ultimately our target would be a B cell so that B cells start producing lesser amount of antibodies and the inflammation would be getting controlled accordingly. Okay. So anti-BAF, this is of more of a theoretic discussion. Coming to maintenance therapy, now we have achieved remission after our initial treatment for minimum period of 6 months. Now the patient is in remission with either a complete remission and now we need to maintain it. So maintenance of remission, it has been divided according to the mild to moderate lupus nephritis and severe lupus nephritis. So mild to moderate lupus nephritis, the first choice would be glucocorticoids and with azathioprine and MMF. Azathioprine and MMF definitely they make good agents for maintenance therapy as compared to cyclophosphamide pertaining to the side effect of cyclophosphamide. And in severe lupus nephritis, it would be better to go ahead with IV cyclophosphamide dosing every 3 monthly. Here it has been mentioned from 2 to 3 monthly, but it advocated to go for 3 monthly for a minimum period of 12 months. That is 1 year. And a complete renal response usually occurs at an average of approximately 1.5 years to 2 years after treatment. So if at all a patient having achieved partial remission after initiation therapy or after induction regimen and you are planning to go ahead with maintenance therapy, it may happen that the patient will respond way later after 1.5 to 2 years. Okay? 1.5 साल या 2 साल के बाद उसको complete renal response आएगा. But this is the period, this is the time where you have to be extra cautious. Your sensor should be utmost active to catch that when the patient is going into flare. Management of NPSLE, these are the various syndromes. Madam has already highlighted about the clinical features, how the central nervous system manifestation and how the peripheral nervous system manifestation takes place. I would better go ahead with actual management. This is the autoimmune pathogenesis of NPSLE, wherein the vascular part as well as the inflammatory part take place, and there is diffuse neuronal loss as well as focal neuronal loss. These are the pathways of CNS dysfunction, especially the immune dysfunction in CNS. Aditya kuthe? Aditya. Achha. He had beautifully highlighted something about the immunomodulation in CNS. So we should definitely thank him for that. This is only summary of what we have, what I wanted to explain. So a flow chart. The flow chart is actually basically only about the diagnosis of neuropsychiatric lupus. It includes a proper history taking, physical examination, lab investigation, and multimodal therapy and multimodal diagnostic tools that needs to be applied for the diagnosis of NPSLE. And once we are thorough with the diagnosis of NPSLE, going ahead with treatment. So the treatment per se in the patients of NPSLE is more towards the subjective features with which the presentation is there. Okay, so by and large CNS lupus is a diagnosis of exclusion. Before you start treating the patient, you have to exclude CNS infection, you have to exclude metabolic symptoms or the metabolic encephalopathy, you have to rule out any other tumors in the brain, whether they are really producing symptoms or not. And definitely after excluding all these features, if you are boiling down to a diagnosis in the background of lupus, then only it becomes a case of CNS lupus. There are per se very few RCTs are not there, but very few observational studies about the management of CNS lupus. And the role itself over here, especially the role of steroids, that how high the steroid should be given or how low should be the dose of steroids, is also a debatable topic. But because it has been found that if at all the patient of CNS lupus is being given high dose, a very high dose of 1 gram per day of MPS pulse, it predisposes the patient to press. Okay. And even there is a faster decline, the cognitive decline is also faster in those patients who had received very high dose of steroid therapy in the patient of lupus. The reason is not known, but these are all the observational studies, and definitely many more RCTs need to be done before we actually go ahead with a treatment schedule. Like the regimen which has been very well documented in the management of lupus nephritis is not there in the management of NPSLE. But steroids definitely would be advisable. The dose of steroids needs to be tapered according to the need of the patient. The induction regimen over here, again, it would be cyclophosphamide or a lesser one if you are not very convinced with the use of cyclophosphamide, because cyclophosphamide again is responsible for PRES, like posterior reversible encephalopathy syndrome. Then you can go ahead with MMF or azathioprine. After excluding the precipitating causes and after excluding whether it is the infective causes. Management of cutaneous lupus in one go. Pimecrolimus, tacrolimus, R-salbutamol. Sunscreen lotions are to be advised to every patient of cutaneous lupus, because the UV exposure is the one which is the harbinger as well as the causative thing for flares. And a cutaneous flare can in future give rise to systemic flare as well. So, sunscreen SPF, what is SPF? सब लोग यूज किया होगा ना SPF. What is SPF? Sun protection factor. कितना होता है? वैसलीन का कितना है? रेंजेस है. क्रिकेटर्स लोग यूज करते हैं ना, वैसे इतना पट्टी लगाते हैं चेहरे पे. हाउ मच इज दैट? वो कितना है? नहीं. Actually, the recommendation actually asks to go for more than 50, but 50 कैसा है ना, 50 जब तुम लगाते हो तो वो चेहरे पे दिखता है. What actually these cricketers are actually using, it is more than 80 and more than 90 SPF. वो इतना thick है कि वो दिखेगा चेहरे पे. But it is advisable to prescribe the patient SPF more than 50 if it is available. If not, 30 तो भी दे दो. ठीक है? Something is better than nothing. The systemic the systemic therapy includes hydroxychloroquine in whichever form of cutaneous lupus you are talking about. The only contraindication for hydroxychloroquine therapy would actually, the patient won't be able to take it. Otherwise, hydroxychloroquine are found to be very safe drugs. These are all other things like thalidomide. Again, the problem with thalidomide is you cannot be prescribing thalidomide to a fertile female. Leflunomide, the same problem. The age group in which the manifestation actually takes place dissuades the patient from the treatment with these higher immunosuppressive agents. Rituximab, our last resort. So this is actually the flow chart in which I have highlighted everything, that whether it is a localized disease or a widespread disease. So if you can see that hydroxychloroquine remains the mainstay of treatment in everything. Okay, so if at all you are having a patient with cutaneous manifestation and you are very sure that is because of lupus, at least prescribe the patient's hydroxychloroquine. We'll see for the side effects in future. The treatment of other systemic manifestation, which include hematological क्या manifestation थे? Leukopenia, lymphopenia. Madam, Tanna bolu de na. It should be interactive much more, because this is the last time when I'm interacting with my residents. Bolo. क्या क्या है? What are anemia? Anemia, thrombocytopenia, leukopenia, और तीन ही में लाइन्स होती है और कुछ हो ही नहीं सकता है. तो hematological manifestation, thrombocytopenia, if at all the count is around 50,000, 60,000, no need to treat it. But definitely if the patient is bleeding, you need to build up the platelet count. We need to see for the level of anemia as well. Low dose steroids with 0.5 milligram per kg usually are indicated in the management of hematological manifestations of lupus. Musculoskeletal, it would be arthritis. It was a very elaborative talk before. So arthritis, myositis. The arthritis part can be managed very well with methotrexate, leflunomide. The way we manage rheumatoid arthritis, the same way we can actually manage lupus arthritis. Methotrexate does play a role. In the respiratory system manifestation, the most dreadful would be lupus alveolitis, when the patient would be presenting to you as ARDS, in which there is some role of high dose corticosteroids. The patient can get benefited with plasmapheresis and IVIG, though again no RCTs report is there. No RCTs have been done, but observational reports also say the same. Cardiovascular system manifestation, right from pericardial effusion, the pericardial involvement, myocardial involvement, non-bacterial endocarditis, it ranges from one thing to other. Low dose corticosteroids with a dose of 0.5 milligram per kg tapered over a span of 6 months is the treatment. Okay, so I think most of the things are concluded over here. So any questions?